Okay, so we're going to be talking about opioid use disorders and pain, and these slides were created by Dr. Bott. Presenting it. Okay, so the objectives today are to describe and understand the clinical import and utility of the comorbidity of opioid use disorders and pain, to understand how treatment for opioid use disorder doesn't preclude the need for effective pain management. Oops, sorry, I didn't get ring of all my dinging. I hope it's at a minimum. And describe and apply strategies to manage pain in patients who are on medication for opioid use disorder. Okay, so first we're going to talk about prevalence. So pretty prevalent, the co-occurring course here for opioid use disorder and chronic pain. So you can see through various studies over the past couple of decades, we have a range of opioid use disorder in patients who also have chronic pain, ranging from 37% to upwards to 64%. And really, we know this relationship's bidirectional, but pain often does come first. So in when we look at adults, in this case, looking at over 5,000 adults who had met the criteria for opioid use disorder from 2006 to 2015, we see that 35% did not report experiencing pain, but about 10% experienced OUD first and then pain developed. About 15% had OUD and pain at presentation, but the highest amount at nearly 40% reported pain first and then the development of opioid use disorder. So very important to be both screening for and assessing both. Patients who have chronic pain before the onset of opioid use disorder also had high rate of other health conditions and mental health conditions as well. And people who had opioid use disorder before the onset of pain were also more likely to have other substance use disorder and also more likely to have positive HIV and or Hep C status, which can be related to potentially to their substance use disorder. So for acute pain management first, and this, I remember Dr. Bott saying that this was a slide that he got from I think, online public material, but it's depicting from a patient the feeling of that acute pain and how overwhelming, as it is titled here, overwhelm, that can be. So here's a vignette. AN is a 45-year-old female whose status post-shoulder surgery. She has a history of opioid use disorder, which was previously treated twice with methadone. She stopped treatment and both times relapsed to opioid use. She had been using a half a gram 2 to 3 times a day of heroin, which she smoked prior to her surgery. So when she was inpatient, she was on a morphine continuous infusion there, and also breakthrough pain, also PRN morphine for breakthrough pain. She last had this dose 2 hours ago and requests more pain medication. Her pain scale is a 9 out of 10. She's tearful. Her vital signs are stable. And the nurse comments that she's drug seeking. She's already getting more pain meds than any other patient on the unit, doesn't need more. Besides, she's an addict and we don't want to worsen her addiction. And this is a commonly held belief that giving pain medication to someone who has opioid use disorder might worsen that. And in that context, we find that acute pain is frequently undertreated in up to 60% of inpatient settings. But even more so, in patients who have underlying addictions. Addiction is in general seen by healthcare professionals as primarily a social problem. This has been studied looking at how this sort of perceived controllability of the problem can be equivalent to blaming the patient for experiencing this illness. And the patient can often be seen as being manipulative rather than advocating for what their pain requires. So what is a suggested approach? You can start by accepting their self-reported pain and knowing that pain behaviors may vary widely from one individual to the next. And that vital signs, as in that patient, her vital signs were stable, but they're not a very reliable indicator of pain intensity. Also important to consider addiction versus pseudo addiction versus actual physiologic dependence. And so kind of distinguishing what is a substance use disorder from physiologic dependence. They're different entities. And if required, not withholding opioid analgesics from people who have substance use disorder. There's no data that suggests that acute pain management is going to worsen their experience of the substance use disorder. And we do know, though, that untreated pain can lead to cravings, and that increases the risk of relapse. 2 studies on patients on methadone maintenance showed that opioid analgesia for acute pain did not increase their chances of relapse. So again, with this suggested approach, because we know that patients who are on opioids, certainly if they're on opioid medication for opioid use disorder, included in that their tolerance is increased, and they likely will need higher doses of opioids for acute pain. And the risk of respiratory suppression due to this tolerance might be lower, but we still need to monitor for that occurrence very closely. And also just important to remember, this question I think comes up very frequently on the inpatient service, in particular, that opioid agonist treatment isn't going to treat the acute pain. It's there for their opioid use disorder, but it's not going to help in cases of acute pain. So we need to be sure that we're addressing that in addition. So what is an approach for acute pain management in the ED? And I'm looking forward. I know we've got some folks who work in the ED, so it'll be good to have some feedback and discussion about this afterwards as well with you all. But you can see this column on the left as a guide. So this is for someone who's on maintenance treatment with buprenorphine. And you can divide the dose, if it hasn't been divided already, to help address the pain more into every 4 to 6 hour doses, but also considering our non-opioid analgesia certainly as applicable. So that can include comfort measures, ice, immobilization, relaxation techniques, NSAIDs, if not contraindicated, acetaminophen, certainly alternatives to opioids or Alto, for instance, trigger point injection, lidocaine, perhaps gabapentinoids. In certain cases, regional nerve blocks may be effective. And then continuing with this column, you can see there some ideas for more advanced regional nerve blocks. In certain cases for ketamine IV push doses, subdissociative doses, or continuous infusion in the emergency setting. And then there may be also a case for alpha-2 adrenoceptor agonists, such as clonidine. Again, so mastering these non-opioid techniques of pain management is really important in everybody, but particularly in patients on MOUD. Again, patients on MUD have that higher opioid tolerance. Also important to remember that if their medication is naltrexone, that has a very high mu receptor binding affinity, and as an antagonist, it's very difficult to treat pain with most opioids. Buprenorphine also has a high binding affinity, and so requires strategy when treating with additional opioids. And then certainly methadone, with its long half-life, it's a full mu agonist, and methadone should also be continued, we'll get into that further, at baseline in acute pain settings, but we need to be cautious and make sure that we're treating on top of it with our short-acting full agonist opioids for acute pain, if those are indicated. And I think what this little bit here, though, at the end is talking about if you had to increase in those in the additional opioids, there's a couple options, right? So there's full agonist medications such as fentanyl, hydromorphone. If you go to the option of increasing the buprenorphine dose, if that's a possible way to treat the pain, again, in divided doses, or starting IV buprenorphine when you're through the acute pain management, then the idea would be at the bottom of this column to titrate down to the maintenance dose. So now shifting gears a little bit to methadone, specifically in acute pain management. We want to try to, in the emergency setting, if possible, verify the dose from their home clinic. If that dose can't be verified, it's important to be cautious. It's safer to break up the self-reported dose into TID, QID dosing rather than all at once. Again, methadone has a very long and variable half-life. And then add in short-acting opiates for breakthrough pain. With time in patient as well, you can gradually increase the methadone dose, and you would not administer buprenorphine because that would cause withdrawal. If the patients are unable to take the oral dose, they can be given IV methadone, but that should be reduced by 1/2 to 2/3 and given in divided doses every 6 to 8 hours. Again, methadone can be prescribed for analgesia in a multiple times a day dosing and can be prescribed by any clinician with a Schedule II license. But you want to use caution even in the pill form dosing. It's still got that long variable half-life. Methadone for opioid use disorder is once a day dosing, although can be split if needed. And this is a liquid form that's only dispensed through an opioid treatment program or methadone clinic. So what about buprenorphine in acute pain management? Again, we want to employ all our non-opioid modalities for pain management that we can. And then certainly first adjust the buprenorphine dosing interval. So if it's not already split, it seems to be more helpful for pain coverage when it is split. So for instance, if we're on 16 milligrams once a day, we could split that to 4 milligrams every 6 hours. And you might also temporarily increase the dose of buprenorphine. So a good rule of thumb is we could increase it by 25%. So for instance, if someone's on 8 milligrams twice a day, we could increase that to 24 milligrams, 8 milligrams 3 times a day. Inpatient, again, we can consider the IV buprenorphine and augment with short-acting opioids that have a high receptor binding affinity. So those would be fentanyl and dilaudid that could be more effective treating at the mu receptor given buprenorphine's high affinity. And then certainly when needed, you can consult with an addiction medicine expert. For peri-operative management in general, we're moving towards continuing people on buprenorphine. Lots of evidence points to that being the most effective and less risky modality, but there is still some lack of consensus in the field. And so often it's based on the preference of surgical and anesthesia teams and communication between teams and the prescribed provider who's helping manage their MOUD is essential. In general, patients may fear mistreatment, providers may fear deception. So just opening those lines of communication in the get-go. And as part of the pre-op process, definitely recommended to confirm multi-party consent and coordination of care. And again, in general, not discontinue buprenorphine. Some people may lower the dose to sort of open up some of those mu receptor availability. If they're on higher than 16 milligrams, they may adjust that down in the peri-op period. And then after surgery, the idea would be to increase to prior and possibly higher dose if needed. So again, current evidence does not support the practice of routine discontinuation of buprenorphine before surgery. Buprenorphine itself is a powerful analgesic and can be combined with other opioids. So we want to have it on board first and maintained. This is the article that has a really nice kind of summary of this approach in surgery by Dr. Lemke and her colleagues out of Stanford. So it's a nice one to refer to. They've got a good kind of visual in this one as well. And then for naltrexone in acute pain management, the patient should be advised, especially if they're taking long acting, so the monthly injectable naltrexone, they should carry a card just so that in a case of emergency, it would inform providers that they're on it. And a suggested plan for pain management is regional anesthesia and the use of non-opioid analgesics. But in an emergency situation, the amount of opioid required just would be greater likely than usual. And just patient would need closer monitoring as that resulting respiratory depression could be deeper and more prolonged. So these patients should be continuously monitored, and opioid therapy should be provided by individuals who are specifically trained in the use of these anesthetic medications and management of their potential effects. So rapidly acting opioid analgesic is preferred, so that short acting, so that it minimizes duration of respiratory depression. And providers need to be ready and equipped for CPR if needed. Tables again, just summarizing kind of the approach in acute pain for methadone and buprenorphine. Again, methadone, just confirming that dose, continuing the regular dose, may divide the dose, and provide short-acting opioids if indicated. It's helpful also to discharge to provide a last dose letter. We need to confirm what that last dose was when patients are returning to their OTP. And for buprenorphine, the preferred approach is this last one, continue the buprenorphine and use additional if needed or full agonist, maximize non-opioids, and divide that buprenorphine dose. Won't read through this whole slide, but it's also a nice summary of perioperative considerations, again, for continuing buprenorphine, methadone, and then for naltrexone, if it's a planned surgery, discontinuing at least 48 hours preoperatively. Certainly elective surgeries would want to discontinue the long-acting naltrexone 30 days prior. And then just need to be careful in terms of resuming it, making sure that they've been off of opioids for a period long enough where it wouldn't precipitate withdrawal when you restart. Again, here's a table just about some of the intraoperative non-opioid pharmacologic agents for multimodal analgesia, ranging from ketamine to clonidine, lidocaine, magnesium, acetaminophen, your other NSAIDs. Again, this slide is showing sort of the multimodal pain management approach, also including some non-medication. Keep that in mind as well, the importance of mindfulness, relaxation, other non-pharmacologic techniques that can be helpful. Switching gear to chronic pain management. This try to wrap up in the next 5 minutes so we can leave plenty of time if there is a case or to discuss all of this. Again, this slide I think Dr. Bott got from online public sources, and this patient was depicting their experience of chronic pain. So some basic considerations. Remembering again that a history of opioid use disorder is the single largest predictor of not taking prescribed opioids as prescribed, and so needing to be cautious, but also we want to make sure that we're treating appropriately. You can consider consulting a pain management specialist and using a multidisciplinary team approach. We want to use our non-opioid and adjunct medications first. So again, listed there, the NSAIDs. There may be in chronic pain more of an indication for SNRIs, namely the duloxetine and venlafaxine. Tricyclics can be, in some cases, very useful. Membrane stabilizing agents, gabapentin or pregabalin, also may play a role. And then making use certainly of our non-pharmacologic therapies. There's good evidence of CBT for pain, acceptance and commitment therapy, and then other therapeutic techniques such as yoga, meditation, acupuncture, and then some of those interventional treatments such as nerve blocks, TENS units, etc. We just want to be very careful with our opioid prescribing, be aware of those individual risk factors, use our screening tools, monitor for behaviors that may be concerning of a use disorder, and use urine drug screens to help clarify and engage the patient in treatment. Monitoring the PMP for safety, and then revisiting, at least on an annual basis, treatment agreements for patients who are going to need opioid pain management. And then certainly always remembering to co-prescribe naloxone. So here's another vignette, this time for chronic pain. This is a 55-year-old female who presents for treatment for substance use disorder. She has a 12-year history of chronic pain following an ATV accident and pelvic fracture. She's been gradually increasing doses of opioids up to 300 MMEs per day. There's some concern about buying off of the street and going to different providers for her medications. She has problems in her relationship, in her work. She expresses worsening depression and anxiety. Her pain is worse than ever. And so some of these certainly are concerning for opioid use disorder, meeting criteria for probably at least moderate opioid use disorder, just on this brief vignette. And so she was started on 4 milligrams of buprenorphine 3 times a day and reported improvement in her pain, feeling happier and better functioning, and that she had her life back. So for buprenorphine in chronic pain, if chronic opioid analgesics are required for pain control, buprenorphine might make it difficult to get analgesia from those full mu agonists, again, because it has such a high affinity for the mu receptor. In some cases, it may need to be discontinued, and a subset of patients with chronic pain and a history of opioid use disorder may experience a reduction of pain with buprenorphine maintenance, and that oftentimes, when it's again in divided dosing, can help more with the analgesic control. There also might be a role for mitigation of opioid-induced hyperalgesia, for instance, quite likely in that patient's case where she was having MMEs upwards of 300 a day. You might see some hyperalgesia from that. And so there are certainly cases where patients experience improvement in that when they switch off of the full agonist over to partial agonist buprenorphine. Here are some reasons why buprenorphine might be a good option as a frontline analgesic. It may be effective for certain pain types, such as cancer pain or neuropathic pain. It's safer. It has that ceiling effect on respiratory depression as a partial agonist. It seems to cause less cognitive impairment and less constipation, though that can still present, and so it's important to address that proactively. It doesn't cause QT prolongation, which we know methadone can. Quite effective in elderly patients, again, for the safety profile. And it's safe in patients who are on dialysis. In general, withdrawal seems to be milder, although some people report that it's not. And oftentimes, if patients are getting off of it, we definitely don't want them to stop it abruptly. This study looked at the conversion of a high-dose opioid to buprenorphine for chronic pain, and you can see here's your morphine equivalents ranging from 200 to over 1,000. And the pain score, the pain before in blue and the pain after in red, after switching to buprenorphine, you can see that there was a significant drop in the pain score. Sublingual forms are not approved for chronic pain, but they can be effective and are commonly used. So this primary use for the sublingual form would be opioid use disorder, but can have a secondary benefit being the pain management. And the buprenorphine patch is approved for treatment of chronic pain that's severe enough to require daily around-the-clock opioid treatment. And you can see here kind of the doses recommended for that in the patient who's opioid naive, and then the patient who is 30 to 80 MMEs, it would be a higher patch. And then you can certainly augment with other opioid and non-opioid analgesics to address any continued pain. almost through the slides here. This is just a vignette for methadone and chronic pain. This is a 64-year-old female who presented to the ER with painful urination. She was found to have advanced cervical cancer with local metastasis, and a need for pain management was identified. There was concern about her 30-year history of heroin addiction and concerns about injection use. She was started on methadone and titrated up carefully at her at the opioid treatment program, and then she was placed on short-acting opioids for breakthrough pain. And really, this succeeded largely due to close collaboration. Again, that communication is key. With her consent between the OTP and her oncologist. So in some cases, patients' opioid dependence, opioid use disorder may be better treated with methadone maintenance because this can avoid complications of precipitated withdrawal from buprenorphine. And in certain instances, having that full agonist may help more for the effective analgesia, depending. Certainly for naltrexone and chronic pain, if they require opioid analgesia, they wouldn't be good candidates for treatment with naltrexone, again, because of that antagonist effect. And you would want to consider using buprenorphine or methadone.